Hi, Jenna. Good to see you.
Hey Rachel, how are you?
Good. I don't know. I mean, I knew that we had talked about presenting this case last month. I'm not sure. Is Dr. Brenner going to be able to attend?
He is going to try. He's
Okay.
on clinics right now, so he thankfully wrote me a case summary of the dog because I consulted on this dog, but I never saw her
Yeah.
primarily. My familiarity with her is like very superficial. Um, but he wrote a very detailed document of which
Okay.
we will not discuss every one of these details about this dog. Uh, so yes, I think there's plenty of background here. And it's interesting because I just lost a burner patient who had juvenile CKD, who had like an AKI, who also had episcleritis, and so it's just
Hmm.
kind of interesting
Well, they are immunologically
challenge.
abnormal. Yeah.
Yeah, yeah.
Let's see. Okay, we just have that on there. I'm waiting to see if any um we've got Dr. Hokamp on. I see Haley's on. I know Jessica is just starting the semester. I think you guys just started teaching this semester, teaching school. So, but she did text me earlier today. Okay. So as we get started, it is recording. And more people will be joining this case discussion. For housekeeping, I like to remind people that we send out emails to request cases for discussion at the beginning of the month. And then we will kind of give you a deadline so that we know what we're discussing. And if cases are not requested within that time frame, then we will cancel the rounds. I am just glancing to see. I will be not available on the third Tuesday, and I don't even think Dr. Hokan will be available. So we might have to cancel rounds in September or shift it by a week depending on any kind of specific cases that are requested. But we are both traveling that day on the 15th, which is the third Tuesday. Um, so she and I will make a decision about either delaying rounds by 1 week or about canceling altogether and send out an email as soon as we've decided. Um, so we appreciate when people request cases, and it's very easy for people to get their final report and say, hey, this would be an interesting one to discuss. We also get cases where clinicians need to um, want more advice as far as how to manage the patient. And so if that ever comes across your desk as well, please reach out to let us know that it's a priority because that way we'll choose that case, especially if there's a specific case discussion afterwards. You are all on the distribution list if you were able to get this email. I am constantly adding people to the distribution list. I try to take them off when I get bounce back emails. If you have not received an invite and it's been a month and you haven't received anything, please reach out to me again because Outlook will haphazardly take people off of the list and they just don't get the emails. And so it can be unfortunate if you think that I'm ignoring you. I am not. It's just a Outlook issue. Um, the Zoom hopes needs to enable recording. I thought I did. It's telling me that it's not recording. Am I not recording? Okay. Well, I think it is recording. I just don't know why the meeting chat is telling me that maybe it's not transcribing. Maybe that's what the issue is. So I apologize if people are um uh trying to or thinking that it will be recorded. And then as these recordings are going through, they do get saved and archived for people that cannot attend at the exact moment the rounds are being hosted. And those are on our site with the uh, AS or ACVNU. So the rounds are shared that way. Okay. Are there any other? housekeeping things that need to be mentioned. Dr. Hokamp, I see that you popped on.
Hi, sorry, I
Okay.
just walked in from teaching. I'm about to run the lab.
I just mentioned that we might not have it on Thursday or next week, next month because we're going to be in France. France.
I'm gonna be in France. I don't
Oh.
know. I'm sorry. I teach like 800 hours today, and I am just
Okay. And soon you'll be hiring to work at there'll be another clinical pathology position maybe posted at Texas A&M, right? Maybe? Oh, was I not supposed to announce that? Okay. We're hoping. Okay.
everyone's
Everyone,
interested.
let's talk about today's case. Unfortunately, if you had read the email from beginning, this is an actual this is a sad case because it ended up being euthanized. And it's also kind of a mystery case. There's still not a complete excellent solution for this case. The pathology is a little unusual from our experience, and the whole clinical aspect of how this progressed is not as typical as as we normally see. Jenna has been voluntold to present the clinical information. I think the primary care physician might not he'll try to jump in later. But he wrote a synopsis for Jenna to present to discuss Bailey.
Hi everyone. So I was not primarily involved in this. I consulted on this dog while she was in hospital. So she was an 8-year-old female spayed Berner who was presented originally to the referring vet in May of this year with a chief complaint of GI signs. So vomiting, weight loss, primarily potential for melena based upon owner description. And at that time, she was azotemic in May with a creatinine of 3, um, and notably had a hematocrit of 65, and was kind of given supportive care. At that time, she was also febrile at 104. Um, they did some very basic blood work. Um, a SNAP 40X was the only infectious disease testing at that time, and then she went home on Clinda. Not exactly sure what was presumably being treated. Was seen again later on that month. This is still back in May. And at that point in time, creatinine had gone to 3.5. She had an abdominal ultrasound with a traveling ultrasonographer and was noted to have some splenic masses and was at that point in time PCR'd for lepto and was negative for that, and then was put on doxy. And did not get better. And this kind of continuation of trying empirical therapies and rechecking things, that happened for several months, of which her hematocrit got up into the 70s. And because she wasn't any better, she eventually landed herself at Texas A&M and through our ER, and was transferred to the internal medicine service. So she had a fever recently, now on presentation had a hematocrit that was more normal in the 40s, and was interestingly slightly less azotemic with a creatinine of 2.5. She had episcleritis and she had an ophtho consult and had some retinal detachment due to uveitis and chorioretinitis. And so she had a big infectious disease adventure, had all kinds of fungal testing, full vector-borne testing at NC State, toxo, and ophtho treated her eyeballs, and medicine treated the dog. She was put on some prednisone, which ended up being about 0.5 mg per kg per day, but she's a really big dog, so that's still a lot of pred, and didn't get any better. had a UPC of about 5 and had a cystatin B performed, which was over 1,000, and at some point got an SDS page, which was consistent, unsurprisingly, with glomerular disease, no high molecular weight bands. I don't know if HoCamp has that, if she was planning on showing that or not. Um, and maybe some tubular damage versus overflow from her glomerular disease. And because eventually the dog was still really sick, she eventually got a renal biopsy. If there's questions about her history, I may or may not be able to answer. But she did eventually get a renal biopsy. I was there for
Jenna,
the biopsy. Yeah, HoCam.
are you actually able to hear me?
Yeah, I
Yes.
can hear you.
Oh, that's amazing. Okay. Um, I'm happy to pull up the SDS page, but as you can see, I am walking
Oh,
to
yeah.
lab, so I can't do it right at the moment.
Yeah, and I
But you
think
can
it
imagine what it
also
looked like.
it's fine. So we can yeah, but it was glomerular with possible small amount of tubular component. And then I think that also the biopsy itself came with more urine as well. So
Yeah.
Hmm.
okay, so uh this is a dog breed that we know has uh a lot of inherent problems with the breed, whether it's histiocytic sarcoma or any other kind of pick your poison for this breed. So we already kind of get a little bit nervous when we see animals from this breed. And I will say, some of the craziest cases that I've diagnosed were on the kidney biopsy, where I'm like, oh, this is not something we typically see. It often is a Bernese Mountain Dog. So I'm always a little bit cautious when I get this breed. I don't think I looked at the biopsy first. I think actually Dr. Lin had looked at this biopsy first, but we were able to do a lot of extra immunohistochemical staining that we don't typically do for our kidney biopsies. I will show you a lot of the histology stuff, so I'm going to share my screen soon. Let's see, let's do, of course, because I did a restart, it's going to want to share. 1 second. Okay. Allow. Allow. Okay. I think actually this is what I want to share. Okay, so we had a good set of core biopsies. We have a dog that has it's a breed that we're concerned about, and it's also a multi-systemic disease with GI disease, ocular disease with some uveitis, and also proteinuria. And so I think this is the reason, is because it's here. So we have quite a lot of things that we're interested in looking at, and I apologize. It's because I did a completely like reboot of my computer today, and so now it's like the whole thing. Okay, share this. Okay, people, you guys can see biopsy cores, correct? All right. So we had a wide variety of cores. A lot of them are just fibrovascular tissue. So when clinicians, when you submit tissue for us, we put everything in the paraffin block. We have looked at it on a dissecting microscope to see if we think that there are um, if there's cortex and glomeruli, but we put everything in the biopsy block. So we process everything. And so this one has a pretty good long core of cortex, and then a few smaller fragments of cortex as well. And even at this magnification, we can see that there's going to be evidence of interstitial fibrosis and some interstitial inflammation with the blue foci there. And then a lot of the samples are just fibrovascular tissue. Some of them have a few myofibers as well. So some things that are just not going to be of use for our evaluation, but there are a good number of glomeruli in this sample. And For the pathologists that are on this group, I know a lot of you don't always look at kidney as frequently as we do. Cystatin B is a urinary biomarker that is it's indicative to some degree of active, kind of ongoing tubular injury. Sometimes, even if you know serum creatinine and it's elevated, you know if the animal's azotemic, but it could be CKD, it could be an event, acute kidney injury event. And so sometimes cystatin B can be helpful for clinicians to distinguish there's ongoing tubular damage at the time the sample was taken. So it's not something that's completely a scarred kidney. There is ongoing tubular degeneration and injury. So the cystatin B elevation tells us that the kidney, the tubules themselves are still being damaged. It doesn't tell us about, well, we don't think it tells us about glomerular function. It should be mostly tubular injury. Um, so at this kind of, overall magnification, we can see there's a lot of good glomeruli. We have a lot of interstitial inflammation. And then we have, which will be a little bit easier to see on the other stains, but we're going to have tubules that are separated from one another and atrophy, as well as so some degree of interstitial scarring. The glomerular tufts have some that are globally sclerotic and kind of are dilated Bowman's capsules. So that glomerulus itself, this particular one right here that I'm pointing out, is not functional. It is a scarred glomerulus. But we have other glomeruli that have a pretty hypercellular appearance. And so um, the H&E is not a great way for us to assess that. Although H&E can be helpful to say what cells are in the glomerulus, it's hard for me to say where are those cells located. So hopefully everybody can see there's a circulating neutrophil right here. So we have a few polymorphonuclear cells that are going through capillary loops. So the nuclei are easier to pick up and identify on the H&E, but then it's hard to say if I'm looking at this group of cells here, which ones are mesangial, which ones are in the capillary lumens, and then which ones might be podocytes. Everything, at this kind of 2 o'clock area of the glomerulus, 1 o'clock, 2 o'clock, everything seems to blur together, and you're really hard to localize where those things are present. But we do know we have some circulating polymorphonuclear cells. And it kind of is repeatable in many glomeruli, although some glomeruli do not have this hypercellular appearance. The other thing that kind of stands out to me is that, for example, over here we have, and it will be a little bit easier to see in our other stains, but we have some really large nuclei, some large cells, and they appear to be within the capillary lumens. So if I'm outlining the capillary lumen right here, there's a huge nucleus in the middle. It doesn't fit with an endothelial cell nucleus. It looks too big. It looks like it's in the capillary lumens. And then if I'm kind of saying like, does that happen again? I can see it kind of does happen again. It's happening in different areas of the peripheral capillary lumens. Um, and it also is a little bit uh, also, it's within that particular core, but it's also in these other areas here. So I've got a huge nucleus here, or maybe this is even two nuclei. I'm not sure. Here's a huge kind of weirdly shaped nucleus, and it looks like it could be in a capillary lumen. But those are not typical things that we would expect to see in capillary lumens. When we're looking at a normal region of a healthy glomerulus, we would expect this with maybe like an endothelial cell nucleus, a few red blood cells, and then open capillary lumens. So these guys are not supposed to be here, and we're not really sure what they're going to end up being. Um, and then along with, again, more interstitial inflammation, tubular atrophy, tubular degeneration, those cells are still continuing to generate, and interstitial fibrosis. Okay. Now, let's see if I can go to the next one. So now we're going to bring in the PAS. The PAS, from most pathologies or pathologist standpoints, helps us localize where cells are. It tells us, is this in a capillary lumen or is this in the mesangium? And now we're kind of in that top long core that had all the glomeruli. We can see that if we take this fuchsia line and say that that's the capillary wall, all around here, we have 5 cells hanging out here in the lumen. So we've got our capillary basement membrane out circling this, and then we have at least one, two, three, four, five, six nuclei within that lumen. That's too many. And then we ask ourselves, is that repeatable? Yes, it is. It's over here. We have three nuclei within that capillary lumen. And then these nuclei are not normal. They're not small. They are irregular and they're quite large. And it even looks like we might have some mitotic figures in here. So some of these cells look like they have very dense nuclei. Whether the question a pathologist always asks is this a mitosis or is this a degenerating like kind of cell that's undergoing apoptosis? And so that karyorectic nucleus gets really dense, um, or pyknotic nucleus gets really dense. And so some of these look like they could be mitoses, but also we have to ask ourselves it could be a cell that's undergoing apoptosis. So that guy out there has too many cells. And then just for comparison, we have other glomeruli that are much more mildly affected. So we've got fairly normal capillary walls in most of this glomerular tuft, and then maybe we only have two capillaries that are expanded by the large nuclei and the large cells. So it is patchy, it is multifocal, it is within certain parts of the glomerulus and not with others. Overall, I would say this glomerulus does not look affected at all. It looks like it's got a fairly normal glomerular architecture and does not have increased numbers of cells within the capillary lumen. So it's not affecting every single glomerulus. Um, and this one, we have here a glomerulus that's kind of undergoing atrophy. You can see how wiggly and squiggly the glomerular basement membrane is, but all of the cells inside the nucleus look really atypical. Sorry, inside the capillary lumens, all of these nuclei look really atypical. And so again, just kind of highlighting the level to which some glomeruli are affected and others are not. This particular glomerulus does have some polymorphic nuclear cells, so we have a polymorphic nuclear cell here, here, and here. So there are some circulating neutrophils as well. And they're probably neutrophils, they're probably not eosinophils. Okay, so our PAS has given us this information that we have cells inside capillary lumens, and that the cells that are inside the capillary lumens have large nuclei, and it is focal, so it doesn't happen to every glomerulus, and sometimes it is segmental. Do the trichrome. Again, the trichrome is going to help us appreciate how much interstitial fibrosis has already occurred. So with our clinical assessment that the cystatin B was up, we would have worried that maybe this is all pretty acute because we have a elevated cystatin B. It doesn't actually mean that. What it means is it's ongoing, right? It means that tubules are still undergoing degeneration and injury. It doesn't mean that whatever happened yesterday, it just means they're still being damaged. So making sure that information about what the cystatin B can be interpreted as is important. Because this didn't happen yesterday. We look at all of this interstitial fibrosis. So we have one tubule all the way over here, and you have to go, you have to hop over a large amount of collagen to get to the next tubule. And the tubules that are present are kind of shrunken and small. And this is probably our only like healthy, normal proximal tubule in the field, and everything else is shrunken and small. So this has been going on for quite some time in this dog. The other thing that the trichrome is going to be able to help us look at is scarring the glomerulus. So a scarred glomerulus is going to have a lot of blue material within the glomerular tuft. And this glomerulus actually doesn't. It's actually ongoing, injured. And we can see our capillary wall all circling around here. And the whole capillary lumen is just expanded by these atypical large nuclei and these cells that are not expected. Go back to our other regions where we were looking before. Again, hopefully this huge nucleus, this should not be in circulation in a glomerular tuft. And I can feel confident saying that because at this point I probably looked at 2 million glomeruli. So it's not something I can be like, oh yeah, it's just, a megakaryocyte in circulation, which sometimes you see in lung. We don't see that in glomerular tufts and just normal in normal glomeruli. This is something that's kind of abnormally in circulation, maybe getting stuck in the glomerulus. But it's not just like something we can chalk up to, oh, sometimes you see that. It just happens. That's not, it's not typical for kidney. Okay, so everybody, I hope all of the interstitial fibrosis can be appreciated. I think I wanna focus on that because I do think it means that this dog has been sick for quite some time, even if we didn't know that the kidney was a big problem. And it would be really hard to come back from this degree of interstitial fibrosis. You can't get rid of all this collagen, it's gonna stay there. You can see how wrinkled the tubular basement membranes are. This right here is what remains of the tubular epithelial cells. And then all of this is just expansion by basement membrane material and collagen. A lot of tubular interstitial scarring. But in general, the glomeruli themselves are not that scarred. It's more tubular interstitial scarring and less glomerular scarring. And our last of our typical of our typical histochemical stains is the Jones. And the Jones outlines the capillary walls really well. So it's going to show us, okay, we have a capillary wall, this peripheral capillary loop, and we have one, two, three, four nuclei inside that capillary loop. Not normal, that's too many. And many of the nuclei inside the capillary loop are atypical. They're quite big. Um, Here is another capillary loop. We circle all the way around this capillary loop, and we have a whole bunch of nuclei inside of it. And so the Jones does help us see, okay, a lot of this is in circulation and not external to the glomerulus. It's not a crescent. It's not in Bowman's capsule. And it's also not within the matrix and the mesangium, because if it were in the mesangial matrix, it would be kind of among a whole bunch of dense black material as well. All the pathologists see how many nuclei. I mean, everybody can see how many nuclei, but I'm drawing this attention to the pathologist. A lot of nuclei in circulation, cells in circulation, I guess I should say. Um, so we were concerned by the hypercellular appearance and the fact that we couldn't tease out what cell was what. And we also knew that the dog was a Bernese Mountain Dog, and so we weren't sure if there was a possibility of circulating neoplastic cells. We had also asked that the blood smear get reviewed, to see if there was a possibility of circulating cells within the blood smear, large circulating cells, uncharacterized. Dr. Hokamp did review the blood smear herself, and commented that there were a couple of cells that were large, but they never really met the criteria of having a leukemic process based on the peripheral blood smear. So at that same time when we're kind of doing that, we also asked for immunohistochemistry to be performed. Hold on. So we did a panel for a whole bunch of leukocytes. We stained for those. And then Jenna, I mean, I guess, is there anything else that was happening at this time? I know that we were kind of considering a bone marrow as we were getting the IHC back for you guys.
Thankfully, Dr. Brenner has joined us.
Oh, okay, great. Hi, sorry, I kind of just landed you on this today.
Uh, who knows, yeah, much about this dog than I do. My recollection, you can correct me, is she was starting to get really sick at this point in time. I think he euthanized pretty quickly. You want
Yeah. Um, we at this point in time we're not kind of looking to dig deeper per se diagnostically in terms of the bone marrow or otherwise. The dog's clinical trajectory was poor, and we were kind of in this prolonged period of time where we were not confident about how to proceed in terms of immunosuppressants for the dog. And so as a combination of how the dog trended without starting something like mycophenolate and the dog's gastrointestinal signs progressing as well, it all kind of culminated in I think a progression of its renal disease in an acute manner, and then they elected to euthanize. So there wasn't a broader diagnostic plan beyond what we had accomplished at this point in time.
And the dog was euthanized at their practice, so we weren't able to get like postmortem biopsy samples or postmortem autopsy samples, correct?
Necropsy was offered and they declined.
Okay. Okay. Hopefully everybody can see the immunohistochemistry pictures. I thought it was easier to take pictures and started instead of trying to upload all of the IHC slides, which we had as well. As we looked at on the histology, some glomeruli were affected and others were not. So some glomeruli looked fairly normal as far as um, cellularity, whereas others had a lot of circulating uh, leukocytes. And so right now we're looking at a CD3, and we have a lot of circulating T cells, and the T cells have kind of large nuclei. Some of the nuclei are even not round, they're a little bit more crescent shaped or reniform. So that is of concern for possibly large circulating T cells. This is another one which shows a glomerulus that has more mildly affected changes. Just to show that not every single glomerulus had the same degree of circulating large cells. Um, we expect in a normal kidney to have, one or two lymphocytes that we catch with kind of these small nuclei, as opposed to what I had showed you previously, which is the numerous kind of clumped together. I mean, they're not really, I don't know if they're clumped, but they are kind of next to each other with these kind of atypical nuclei. Um, CD20 is for B cells. It was pretty much negative within the glomeruli. You can see occasional B cells within the interstitium. That goes with what we normally would expect. We did a macrophage marker. Oh, actually, sorry, it's a monocyte marker based on what Texas A&M has available. So they have a monocyte marker, which is a MAC387. They don't have available a few of this IHC that I also would recommend, which would be a specific histiocyte marker. They didn't have that offered. We do have a few cells that are labeling positive for monocytes. Um, and I don't really run that marker that often. I think a couple people, I think Sarah probably has a little bit more experience with it. It does seem like it's kind of staining the irregularly shaped cells. They don't look as big as the CD3 cells, but that it does stain quite well. So that's another mic 387. We also looked for possible if it was plasmacytic for like a myeloma process, and that is negative. The only positive cells we see are in the interstitium, which makes sense because oftentimes we have lymphoplasmacytic inflammation. And so here again, nothing, these atypical cells inside the glomerulus with this kind of crescent nuclei or reniform nuclei are not staining, but we do have plasma cells within the interstitium. And there's one more. Oh, this is again just to show the plasmacytic inflammation. So we were concerned of maybe like of a T cell process, uh, based on the fact that there were large circulating atypical T cells, they were in the glomeruli. And then just compare, I guess another thing that I probably didn't harp on is that we've got these kind of very large cells with the positive staining, and then if you look at what we think of as normal T cells in the interstitium, they have much smaller nuclei and they're not as big of a cell overall. Um, so again, we would have needed more evidence of a T cell dyscrasia or neoplasia. We would have needed a bone marrow to help us think that maybe they're being produced and getting trapped in circulation. We would need PAR maybe to show that they were clonal, which we did not request because at this point I think the patient was euthanized. But there's something abnormal about the T cells, and they are kind of getting trapped in the glomeruli. We did do EM on this because the EM had already been submitted, and so we went ahead and followed through with that. And I can show you the EM in just a moment. I think this is one. Hold on. I was very vague with the diagnosis, but I just said glomerulopathy characterized by large circulating leukocytes, and there's podocyte injury that's going to show up on the EM. So again, very vague because I wasn't sure exactly what was going on. Way back when, it was probably about a year ago, we did present a case at Rounds, which had a circulating leukemia, or no, a circulating lymphoma, intravascular lymphoma. And we caught it in the glomeruli, and it was also caught in other biopsies of that patient because they had biopsied the GI tract as well. And so even the person that read the GI biopsy had said circulating lymphoma. And I'm pretty sure Mary Nabity, or if you were on there, I think it was T cell.
Yeah.
Did
Okay.
that patient have ocular changes as well?
I don't know. I can pull it up. I don't know. I have to remember which case it is, but I will find it. I don't think it was a Bernese Mountain Dog, but I can look. I think it was like a golden or something. Um, but that was a little bit easier, right? Because we had multiple systems that had the vessels that had the atypical cells in it, as opposed to this. At this point, we only see glomeruli being affected. We don't really even see tubular interstitial, like peritubular capillaries having the cells. It makes it a little bit difficult for us to call it just on this. And obviously, if we had more tissue from the patient, we might have had been a little bit more successful. When we did the electron microscopy, the glomeruli were not the best, the ones that were submitted in glutaraldehyde, because you can see up here in this upper left quadrant, see how wrinkled the GBM is? That's kind of a scarred or ischemic glomerular tuft. So it's not, if I had a whole bunch of glomeruli to pick out of, this would not be the one I wanted to scope. However, this is what we had, so we scoped it, and I think there's two glomeruli. So one of them had the wrinkling. Um, but you can see even on the other glomerulus that is not as kind of not as scarred, it still has wrinkled capillary walls. So let me make this a little bit bigger for you guys because it's kind of within the screen. But hopefully you guys are seeing that this undulating capillary wall, undulating GBM, and that is, an area that is kind of collapsing down or ischemic. And if you compare that wrinkled part to the area where it is more open and not as wrinkled, that this capillary is being better perfused. And then we have our podocytes, and our podocytes are a little bit larger than we would expect, and they have pretty much global effacement of the foot processes. Here's another podocyte. He's just sitting right on top of that GBM, and he has like no foot processes available. So this was our evidence of podocyte injury. Here's another, it's kind of that zoomed in area. So this is the nucleus of the podocyte. Here's our cytoplasm of the podocyte, and it's sitting right on that GBM, and there's no foot processes. We were at least able to say, like, the glomeruli have the circulating cells. Unfortunately, the glomerulus that were, or the glomeruli that were scoped for EM didn't have the circulating neoplastic cells, or suspected neoplastic cells, I should say, didn't have them in their section. We didn't really have a really good section with an atypical nucleus in circulation. We just had the podocyte injury and glomerular ischemia with only a few patent capillary lumens. I think that's our last EM. So, I guess I should say one thing as well. I'm kind of getting off track, but if you're looking at our good capillary wall, this is one of our good open capillaries. There are no electron densities within the GBM. There's no subepithelial, subendothelial, or intramembranous densities. So I don't have any suspicion for immune complexes based on EM. We actually did not do immunofluorescence for this case because we had spent all the money on doing the immunohistochemistry. So we had used that instead of performing the immunofluorescence. However, based on based on the ultrastructure, I don't have any evidence of immune complex disease either. So I don't think we missed anything with not doing the immunofluorescence. Um, this has a very descriptive end diagnosis that we have these circulating cells, and then we have podocyte injury. And I don't know how if the two are even interconnected. They might not be interconnected. They might be just two separate processes occurring in the same glomerulus. Um, are there any specific comments or questions, especially from the pathologist who might have a little more experience with these kinds of atypical circulating diseases? Hmm. Anyone?
I just
Okay, we have
remember
Dr.
at the time I was like, with it being so T cell specific and like them not reporting a mass, I was just, very concerned about intravascular lymphoma, but I totally agree, like that you don't have a bone marrow to indicate that there's not a leukemia that's
Right.
occurring, but that's kind of what my concern would be.
Yeah,
And
and we have Dr. Cooper, which then I guess maybe we've had three cases now because Dr. Cooper said that there was a lab cross that was diagnosed with intravascular lymphoma and it was diagnosed by us, but it also did have ocular changes as well. Um,
and Rachel, I put it in the chat for you. Our case echo, it was a Siberian Husky and it was confirmed CD3 positive.
okay. Oh, I don't see that in the chat. Interesting. It didn't pop up. Something might be wrong with Zoom. Um, that so, and we know we also had biopsies from that dog on the GI tract. Did we know if it had any ocular disease? You're right, it is Echo. That name sounds familiar. And it was
I'll look some more.
okay. So I mean, I guess we could if something where is a scenario. I mean, intravascular lymphoma is an entity that exists. Oh, thanks, Dr. Cooper. That's great. Um, uh, so I don't really know if it's something like we would publish it in general to say, we found more examples of it, and sometimes you catch it on the kidney biopsy. But if we wanted to, if it was something where we wanted to do or a case presentation about it, we would probably need to do PAR on the tissue block that we have to see if the T cells themselves are clonal. That would maybe support that it was a neoplastic process. Um, and we can send that to Colorado State if that was something we wanted to pursue. I think the euthanasia kind of happened over a weekend, and so we really didn't get a lot of extra time to figure this case out. Um,
Yeah, I will say is iffy. I mean, the more we learn about PAR, it seems like the less we know about PAR. Um, and I don't know if that I don't know how much that actually helps us with this case and frankly any other case. I mean, I had a case this last year that was a cat who had an infective ureterolith, and we end up having to nephrectomize the cat because it had a renal abscess, and we tried to do another surgery, and because it was like the kidney was like obliterated by this pus-filled exploding thing, we determined it wasn't salvageable. And I submitted it for histopath. Honestly, I don't know why I did that to myself. Because then, so this cat, this was like a year ago, the cat's still alive. On histopath, it had in the interstitium, it had plasma cells and lymphocytes, and somebody said, well, this seems like there's a lot of lymphocytes. And so then they did some staining and there was a lot of CD3 positive cells. And so then they did PAR on it. It was PAR positive. And so they came back and said, this cat has renal lymphoma. And I, I, the cat's still alive and it's doing great. And I just have a hard time. So I have this like random diagnosis now of quote unquote renal lymphoma based upon PAR. And there's lots of examples in the GI tract where that didn't work out.
yeah.
Uh,
And that wasn't us, right?
no.
Okay. I think so yes, I think if the par were negative, then we would say, okay, well, we don't have this extra piece of evidence to say that if the par on Bailey is negative, then we know at least they're not a clonal population that's hanging out there. Granted, we only have 10 T cells in one glomerulus and 10 T cells in another glomerulus, so it could still be negative and be like, well, it's just probably not picking it up because it's such a small population of the entire sample. I agree. I think even if you knew there was a really bad infection and there's a lot of T cells on histology, and even if they are clonal or you have one of them, there's a little bit of a clonality in there. If there's not an actual mass and there's not a TIPI in the T cell population, I would not have called that T cell lymphoma in the cat kidney. So I see exactly what you're saying, and that's one of our frustrations, I think, too, from just a diagnostic pathology standpoint, because I can see some of my colleagues from Zoetis are here. Like we just don't do flow anymore. Like we don't do flow on tissue hardly ever, and it's really unfortunate that we don't have better ways of analyzing cellular morphology other than from H&E, paraffin embedded, which isn't great oftentimes, especially when there's necrosis, and then having the molecular information that there is clonality, um, or lack of clonality. And then obviously you can have clonal populations in response to an infection because that's all the cells that are coming in to fight that particular antigen. So it is unfortunate. Yeah, and I think Dr. Limperano's comment too is about which place it's sent to. A lot of times, Colorado State doesn't actually look at the histology when they interpret the PAR. They don't do the IHC they just do PAR, which can be troublesome because those two should kind of be interpreted together. I think Michigan State does most. They do both of them together, but then it's a lot more expensive. Um, so, um, so we have a couple of pathologists on. Yes, it can be stressful to interpret the IHE and PAR together as opposed to just getting that information. So in the end, this dog sadly uh, progressed. However, I hope the owner knows, and I hope it's communicated to them that there was a lot of scar tissue in this kidney, no matter what. And even if we were like the very first day the biopsy came in, we would have said, "Yep, it's this." There would have it would have been hard to recover these kidneys, because of the amount of fibrosis that was already present. So this wasn't just something that was injured 2 days ago and was salvageable. And so I hope it gives them a little bit of information of like this was a really scarred kidney, and yeah, the scientifically we're interested in what caused the scar and what caused the disease, but it would have been really hard to recover these kidneys. And if the dog was progressing clinically, then um, it was likely always going to go this way as far as deciding to euthanize. Um, I hope that sometimes that's even the information that I want to communicate. It's not always just like this is what the original disease was, but like, yeah, this is a good kidney. We can work on this kidney. We can keep it going. Or this was a really scarred kidney. It's going to be hard to treat this case. Okay, so we had a couple of other comments. Oh, I do see you. You did actually message me just directly, Dr. Nabdi, and that's why I couldn't find it. Okay. Um, so any other comments? Any other pathologists that have seen this kind of circulating stuff inside glomeruli and um concern for that?
I was just gonna chime in quickly and agree with Sarah and everyone as well. I had a case back when I was a resident that it was a golden retriever with intravascular lymphoma that was primarily affecting the CNS, but I'm pretty sure there were circulating cells in glomeruli and in the liver, and I want to say also the spleen, that just had a quite a similar morphology, and that one ended up being CD3 and MUM1 positive, which is always a little weird to me, but T cells are T cells, so whatever.
Yeah, even Mom One doesn't do like everything. We're like, this is the brand new marker, and they're like, oh, it stains everything.
Yeah.
Which is like how are we saying like PAR's gonna solve everything, and then it's like, oh wait, it's not gonna solve everything. But again, it's the weight of evidence, right? Like it's putting all the pile together and say, we have this, and then it would be nicer if we could do flow and we could do a lot more markers on well prepared samples. I mean, even diagnostic flow, like our friend Holly Minard reads them for IDEX, and a lot of times diagnostic flow to see like just to diagnose leukemia through IDEX is hard because by the time the sample gets to IDEX, it's a lot of the cells are dead. So no matter how well the clinicians prepare the sample. So diagnostic flow is very different than research flow. Research flow can be very well prepared and then just go right down the hall and put it on the machine and all the markers are labeling perfectly. But when you're talking about diagnostic where it's only offered in a couple of places all over the country, and so things have to be shipped there, it can be very difficult to say what the subtype of leukemia it is. Um, Instrument, not machine. I'm not supposed to say machine. Why? Is there a reason, Dr. Hokim, I'm not supposed to say machine?
There is. Can you hear
Please
me?
teach us. Yeah.
Oh, well, no, I can't teach you right now because of what's about to happen in here in a minute, but there are reasons. But it's an instrument, not a machine.
It's been beaten to our heads. over and
Yes,
over, and it
Is
may
it
or may
just
not be accurate,
because
but
it's a
that's just
tool?
how.
because it measures something.
I mean, my scale's a machine and it measures my
Nope,
weight.
it's an instrument.
Okay, well, now we're gonna have words. Okay, you guys, you don't have to listen to all this. Uh, okay, so I think if there's no other questions, does anybody else have any random comments about or questions about kidney? Because we still have about 10 minutes. But obviously, if we are done with that particular case, Dr. Brenner, did you have any other comments you wanted to make about Bailey?
Um, yeah, two things. One is I just
Okay.
want to say thank you for everyone's efforts in helping us evaluate this case, despite the outcome, because it was educational despite not having all the information. I think that from the resident and clinical perspective, the challenge with this case is you are kind of approached with an uncommon presentation, and then it's already progressed clinically and also histopathologically, and then you're trying to ferret out differentials and while making a proactive plan. And so I think for this case, it was more just trying to have a more expedited diagnostic approach would have not necessarily, as you've already alluded to, led to some resolution, but I think I could have potentially provided an improved quality of life in the remaining weeks that it had, or at
Hmm.
least provided better guidance to the owners while we were trying to kind of ferret out the underlying cause. Because a lot of the time it was this empirical supportive care, which we knew wasn't sufficient, but we also didn't have the information to know what a more targeted approach would have been. And so I think not that that speaks so specifically to all of these things you found on histopathology, but more just from the clinical perspective, kind of a where kind of what I'm taking away from her case.
Yeah, and I think that's really important. I think we get a lot of samples that come through, and because even though it's within your own hospital, because it went down the hall to Texas A&M, the pathologists are all remote, and so we do have to wait for the slides to be scanned. We a lot of our cases that we get biopsies from are stable, and they have had chronic proteinuria, and it's been going on for 5 months. And so we at least can give them the reason, and we can give them a good idea for case management. But those are like kind of like the FSGS cases, maybe the amyloid cases or something like that. For these really atypical, unusual ones, or if it clinically it seems unusual, um, uh, you know, we need to uh, probably be better at communicating of like this is going to take a while, because it's not something that is the typical thing that we're going to see. And then it's always going to take at least 2 weeks for us to get the EM back. We're pretty, we are pretty good at making sure the EM comes back in 2 weeks. But no matter what, it's just going to take that amount of time. So I think a lot of the clinicians, especially that are on this chain, know us fairly well, and so they can kind of nudge us to say, "Hey, this one isn't typical. Like you need to flag this one." And we would be kind of triage it mentally in our list. But I think that once the biopsy has been taken, it takes a while to prep everything so that we can get our electron microscopy stuff back. So it's always going to be a little bit of a slow diagnosis when it comes to kidney biopsy, unless we can say, oh yeah, it's amyloid. This is no reason to do all the other stuff. So,
Yeah,
um, mhm.
yeah, I appreciate how the sort of embedded logistics or inherent logistics to it, and um, and as I mentioned, even I think you all took a look at it over the 4th of July holiday. So that was very appreciated. I'm very grateful for that. I think from the clinical perspective, in hindsight, I wish I had proposed renal biopsy earlier. Like because we were in post discharge from the initial hospitalization, we were still in this place where we were like, is this a PV case? Is this due to renal pathology? Like, I wish I had recommended something more proactive earlier. Not that it may have ultimately changed the prognosis, but just so I could get the sample sooner to you guys.
Yeah, yeah. And I mean, I think that's a lot of times too, especially a lot of people that are here that are tertiary care. is like the primary care has been managing this dog for 6 months or whatever. I mean, not for your particular case, but I get that kind of
It had been months, Rachel. It was months that
Okay.
she
Yeah.
was managed by the primary care for 2 months by that point in time. I mean, it was early May to early July.
Yeah.
That was sort of one of the things that struck me. This dog's disease been cooking for a long time before you guys saw it. Another piece of it is that I don't understand quite why the hematocrit was so high in that period of time, which again, and with cells that are atypical uh, and in places they don't belong, one wonders about cell dyscrasias, whether they be bone marrow or otherwise. I also wonder a little bit about a number of those histology of glomeruli, regardless of whether we know exactly what the cells are or whether they're normal or abnormal. Capillary lumen, or the space inside the basement membrane, is choked with cells. Okay. Well, that's going to make perfusion poor, and maybe oxygenation poor, and maybe the dog's bone marrow is getting signals from its kidneys that it needs to, increase hematopoiesis. Now, I'm not saying that we got extramedullary hematopoiesis in the kidney, but and again, once we're that far down the road with all the injury and stuff, and of course the people's patients and pocketbook are sort of used up, and the idea that we'll get somewhere that'll help this dog, and the dog's suffering and getting worse, the giving up and is understandable. And I understand them refusing the necropsy, but I've had personal experiences with not having the answer to a case until not just necropsy, but during my residency, I had a dog with renal failure, hypertension, detached retinas, all this, and the dog died or was euthanized, I can't tell you. And the necropsy was done, and Steve Bissner took the dog's eyes for his own histopath to do. Months later, he came to me and said when he did the histopath on the eyes that he'd collected at necropsy, he found blastomycosis in the retina. So, and that's at a time when we didn't have good serology for systemic fungal agents, but it was in Minnesota where we grow blastomycosis cases. But the point is that sometimes you don't get the answer until you take the dog apart carefully at the end, and we need to be prepared to do that, and if we can, and take advantage of that. But you did everything you could during the period of time you had, and you were coming in on the end of the disaster.
Yes, that's unfortunately that's how it ended up happening. And hopefully, I mean, I think we're probably about half and half of how many cases we present that end in decision to euthanize versus ones where we can give them information that they can be used and like, oh, the animal's doing great now. So hopefully, as we get more and more cases, we can have more of the success stories as well. So as we're wrapping up, Dr. Hokamp, Dr. Nabney, and I will decide whether or not we will host rounds in September. And we will let you know as soon as possible whether we decide to do that. And then we will, if not, continue in October. And let me know if there's any questions. And also, if there's ever a case that comes across your desk that you would like to discuss, just flag us. We do keep a list so that we know which ones we can discuss the next month. Okay, thanks, guys. It's good to see you.
Thank you.
Thanks.
Bye.